नो कंप्यूटर स्विच करने में इस पे भी इसमें कोई डाउट नहीं है, यहाँ से नहीं ना शेयर नहीं हुई अभी कर लूँ round and round and round. So what is happening is मैं करूँगा. So what is happening in your system? ना ये नहीं हमारा नहीं कितना मैं कर लेता हूँ कोई ठीक है just wait ये वाला मेरा वाला है Dr. Sukhbir, can you see my slide?
Yes, sir. देख रहा हूँ सर.
Okay. Full screen already ना? ये full screen ये देखो ना, ये देखो. Full screen है ना, ये देखो. वो देखो. Multiple display, तो एक display कर. ठीक है वो मल्टीपल डिस्प्ले है So good morning. Your system is very slow. Yes, slide yeah. So I will be talking today about digestive disease management issues, some of the issues in relation to management of digestive disease during this COVID-19 pandemic. Now we all know that COVID-19 is the disease caused by a virus called severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2. It came from Wuhan in China. And then from Wuhan in China, it spreaded all over the world. Probably in the century, this is the biggest mishap that has happened. And it started from Wuhan in China. Whole world is jeopardized, the human life, the industry, the economics, the education, the patient care, everything is jeopardized. Now, obviously, in India, we first came to know about COVID-19 patient in Kerala in 30th January 2020. So in Kerala on 30th January 2020, we came to know that there is a COVID-19 patient. Subsequently, if you see the Indian map, it has spreaded all over the country. The size of the dots there represent the number of reported cases. And as you can see, some parts of the southern India and Delhi and Maharashtra, they have the largest number of patients. Now, when this COVID-19 began, how we responded to it in the specialty healthcare. I am a gastroenterologist at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And let me tell you how we responded to this pandemic or this epidemic after it has begun. Also will introspect how to go further, because healthcare has to remain. We know now that for a period of time, the care of patient with other diseases got really jeopardized. But we have to bring back this care of many other diseases onto the track. Also, it is important to understand that if we do not give care to the patient other than COVID-19 patient, probably these diseases would also take away lives of people. Also, we'll say how to go further. What should be our strategy? Now, when the lockdown was on and we did not have much to do, then from our basic understanding, from our introspection, this is the review article that we wrote. This review article was written by Gerald Holman from Australia, Eamon Quigley from US, Ayesha Shah from Australia, Michael Camilleri from US, Victoria Tan from Hong Kong, Koken Givi from Singapore, Kentaro Sugano from Japan, Joe Solano from Philippines, Professor Fogg from Singapore, myself from India, Minu Chen from China, Axel Dignas from Europe, and Henry Cohen from Europe. Now, we just did not know how to go about things. So we introspect. There was an emergency phase when the country was totally locked down. In fact, world was locked down. What did we do then? We curtailed our services. No service, or practically very little service, to care of patient other than COVID-19 patient. They would otherwise need the care. Only emergencies were open. We all know that resources were reallocated towards crisis management. That means every specialty doctor, they had to care for COVID-19 patient, and therefore they had to actually make themselves somewhat away from the care of the patient for whom they were earlier meant for. For example, we know one tower of our building, which actually used to admit patient, was converted to quarantine. Therefore, this tower, like in gastro, there were 60 bed, 30 bed went to quarantine. So we were working only with 30 bed. Staff and patient protection obviously was important. So therefore, we were really in a sort of panic how to get all those PPE kit, how to get the mask. So this was an emergency phase. And this was predominantly a health system response. Now we are in an adaptation phase. What is the adaptation phase? We have to find out alternative method for service delivery. That is very, very important. We have to implement those service delivery system, including making the guidelines and the protocol. So this is the next system which we are going through. And the last phase is consolidation phase, because it is important to understand, probably we have to learn to live with this virus. Maybe this virus will not leave us. We have to learn to live with it. So we have to review and refine our services. We have to plan, we have to check, and we have to prioritize services based upon the risk and the patient need. It is like now in endoscopy, what we are doing. We are saying if a patient need is very less for an endoscopy, let us say a simple patient who has little dyspepsia or heartburn, one would not do his endoscopy now, but earlier he would have got an endoscopy. On the other hand, if there is a patient who has GI bleed, even if he is coronavirus 19 disease, now that patient will also undergo endoscopy. So we are prioritizing, we are triaging which patient really needs the most, and there, in spite of all the risk, we will undertake the endoscopy. but if the patient need is less, then will not undertake. So in fact, when the lockdown was on, maybe in April, May, or little earlier than that, we did a pan-Indian survey among gastroenterologists. What we did is we made a questionnaire. This was a collaborative effort of Apollo Calcutta, SGPGI Lucknow, and Asian Institute of Gastroenterology in Hyderabad. And what we did is we asked 373 endoscopists across the country how many endoscopies were they doing compared to what they would do before. And I tell you, what we found is only 10% of the endoscopic procedure, 10% of the endoscopic procedure, which were happening before the COVID-19 came to the India, were being done by them. That means 90% of the endoscopies, they stopped. We asked them, what is their viewpoint? Should the endoscopy be continued or should this be stopped? And you can see as high as maybe 26, maybe 59 or 60% said that only do emergency procedure, but stop all the routine procedure. In fact, around 5% were so extreme, the gastroenterologists, they said stop all kind of endoscopic procedure. It is like that was a panic reaction then, but I tell you, it is clear from this survey that 10% of endoscopies were being done in the country based on a survey of 373 gastroenterologists during the peak of the first wave of coronavirus disease 19 in the country. That means maybe 90% of the patient who would otherwise undergo an endoscopy earlier before COVID-19 began would not get the endoscopy procedure for them. Now one can say, would it lead to real loss to life? May not, because many of the endoscopic procedures that were being done earlier were not the life-saving procedure, they were diagnostic procedure, but still we can say 10% were being done. Now we asked them, were they getting adequate PPE kit? And I tell you that India has done reasonably well in management of COVID-19 in spite, although I know that some people will have reservation on my statement that I'm making, but if you look at the global situation, India has done reasonably well in COVID-19 control or management than what many countries, such as those in South America, some of the European countries did. And you can see most had facility to have a surgical mask, 92%. Yes, N95 mask was available in 74%. And initially we know a lot of these N95 masks were being imported from abroad, but we know now much of the N95 masks that we get are made in India product. Now they were getting shoe cover, they were getting hairnet, they were getting face shield, they were getting complete PP. Only about 0.8% or maybe 0.3 to 0.8% were not getting adequate PPE kit. They were only getting a pair of surgical gloves to do the endoscopy. Those must be in the very remote areas, but I think this should be also corrected as time goes. Every doctor who is doing an invasive procedure such as endoscopy, which is very, very aerosol generating procedure, and they must get adequate PPE kit. Now, this is what the chart that we made in that review. We said initial response was very rapid response, but subsequently we have to think about the delayed response, which is to be planned response. And we'll review some of these issues as I go on presenting more. Now look at this. This is a graph from that particular article. So initially you see there is an interruption. There is a capacity constraint. And that time, actually, yes, like what I said about endoscopy procedure, there was an interruption. Only 10% of endoscopies were being done, 90% were actually suspended. But this is like a panic response. This is like an immediate response. This response has to now be planned in a better way so that the patient get the care what they need. At the same time, the medical fraternity need to be protected. So what happens is this has to be done. Policymakers, the medical personnel, everybody should join hands to plan things in a proper way. Now, what about outpatient services? Yes, outpatient services were similarly interrupted because we know that 85% of COVID-19 patients are asymptomatic. 85% of COVID-19 patients are asymptomatic. In fact, if you get a younger fellow with COVID-19, he's more likely to be asymptomatic. We did a study among 252 patients with COVID-19. What we found was very interesting. If somebody was less than 15 years of age, 100% chance he would be asymptomatic. Whereas if somebody is more than 15 years age, about 15 to 20% chance that he will be symptomatic, 80 to 85% is the chance that he is asymptomatic. So that means if you get a young guy, he can still harbor COVID-19 without fever, without cough, without pharyngeal symptom, without respiratory symptom, without GI symptom. So in the OPD, if you meet people, the doctors meet people or the staff member meet people for physical consultation, knowing that 85% of the COVID-19 patient would be asymptomatic, actually it will lead to a real mess. We know that almost 600 medical personnel like doctors have died in the country, and we know that doctor-patient ratio in India is very high. That means you have much less number of doctors than the number of patients you have. Now, if we lose doctors further, then obviously the ratio is further going to be jeopardized. How to bridge this ratio? How to sort of fill in the gap? One way is filling in the gap is in the doctor's hand. We need to protect ourselves so that we can continue to live and give service to our patient, but the other remains with the government so that they can give enough facilities to protect infection among the healthcare worker. The still other facility remains with the government, which I'm not going to talk about here, is population control. If your population keep on increasing by any number, by increasing number of doctors, this ratio is not going to be better. This ratio would remain the same or would become worse. So I'm going to talk about what was our strategy to give health care to our patient during the lockdown, and we'll learn from it. Should we continue the same in future? So what we did is we developed an electronic outpatient system in a website which I started in 2010 or maybe 11. So this website was readily available to me. In the same server, I started an electronic OPD, taking the help of some of the computer personnel like Priyanka. And then what we did is that if you click here in this stethoscope, it will open this form. This form will ask the patient to put his or her name, age, gender. Then it will ask for what are the patient's chief complaint, who has referred this patient to us, and then patient will say what is the appointment period that the patient want. Like somebody can say, I want an appointment between the next Wednesday and Thursday. So therefore, the patient will be given appointment preferably during this Wednesday and Thursday. So once the patient submits this form in my administrator panel, I would approve the appointment. The moment I approve the appointment, in the right side of the website, right side of the home screen, the patient will see appointment requested for, he will move to appointment schedule. So appointment requested for, the name will move to appointment schedule. Now, once this is done, patient knows that he requested for an appointment and the appointment has been scheduled in so and so date. Now, after that, what did we do? In the same date, when the appointment has been scheduled, actually, patient makes a WhatsApp video call. And in fact, I bought a tab for this purpose. This is the tab, in which patient become face-to-face through a video call with the physician such as me. So you can see here, this is Moni Chaudhary, who works with us, research assistant. This is Sikha, who is PhD student, and this is Prasant, who is a research assistant. They are all helping me. So by a video call, actually patient is seeing the doctor. And it was worth seeing some of the scene. In a village, there are beautiful green around. The fellow is sitting below a tree, And now there are 4 other members of the village or 10 other members of the village who are looking at that video consultation. And they are seeing that the patient from their own village, from below a tree, is consulting a specialist doctor at SGPGI through a video call. It is as good as a physical OPD without need for traveling. And I'm telling you, we are lucky that for 12 years, Telemedicine Society of India has been trying to legalize telemedicine, but was not happening. But once COVID-19 came, everything was done in emergency and teleconsultation was legalized. And maybe this is what is the vision of Prime Minister Modi, Digital India. What is Digital India? A fellow sitting in the village can consult a specialist doctor in SGPGI or many other tertiary center through a video call. So we have actually compiled this experience with 50 patients of inflammatory bowel disease. With 50 patients of inflammatory bowel disease, we have compiled this experience, written it as a paper, and currently the paper is under review in an international journal. I will talk about our experience, what is given in this paper. So what happens is the period of compiling the data of this teleconsultation was 28th May to 16 July, 28th May to 16 July. That means about maybe 1.5 months or little more. So what we did is we saw 50 patients of inflammatory bowel disease. Of them, 29 were from urban areas and 21 from rural areas. Now, all of them could be seen by video call, except in 10, the video did not work because of the poor bandwidth. So what happened is the fellow could not connect us with video. So he did not have an opportunity to see the doctor here, or we did not have the opportunity to see him in the village or town. So it was only an audio call. So 10 were seen by only audio call, no video. And you can see here of these 10 patients, 5 actually had to change from video to audio, because the moment you put the video on, the connectivity was poor because of the less bandwidth, and the 4 were from rural area. That means what you can see here, this connectivity problem is happening more in rural areas than urban areas. Now, of these 50 patients, if they had to visit us for a physical consultation, let us say if we had to come for a physical consultation, median distance to be traveled would have been 174 kilometers. So that means he had to travel 174 kilometer median to reach SGPGI, and you can imagine the agony of traveling 174 kilometer by bus, train, car, whatever it may be. So this was mitigated. Interestingly, travel distance was comparable among patients hailing from urban and rural area. What does it mean? That means SGPGI is as popular in rural area as in urban areas. And it also tells us that even urban area does not mean Lucknow or Kanpur. People from far off urban areas also come to see doctors and SGPGI, which actually talks about the reputation of the institute. Now we asked the patient question. We asked, do you think that the connectivity was good, average, or poor? As you can see, 35 of 50 patients says good connectivity, 9 said average connectivity, and 6 said poor connectivity. So majority had a good connectivity. But if you look at the urban area versus rural area connectivity, you can see in urban area out of 29, 4 had poor connectivity. But in rural area out of 21, actually 11 had poor connectivity. So connectivity problem is happening more in rural areas. Now that takes us somewhere. Prime Minister Narendra Modi's vision is Digital India. And Digital India is a power to empower. And you can see here in this photograph, the 2 rural people, one a man and one a lady, are chatting in mobile. But let me tell you, these are good for advertisement. But the data that we are showing actually shows or actually helps us to introspect that we have to go further. We have to connect the rural areas better so that the Digital India initiative actually become robust, more successful. Now, SGPGI started an eCCS system. So what is eCCS system? Electronic COVID Care System. Now, what happens is eCCS system was started in the beginning of the epidemic, and we have given consultation from eCCS system. And I tell you, eCCS system consultation is typically like a telephone consultation. It is not a video consultation largely. Also, eCCS system has a limitation. What is the limitation? Like whenever I sat in the eCCS system, I know a neurosurgeon patient is calling me, let us say a urology patient is calling me, or nephrology patient is calling me. What I did is, or what I was supposed to do it, is to connect to the neurosurgeon or connect to the urologist. But I tell you, that is like you are a media person, you are a mediator, and you are not giving the care directly. As time goes, each department or each specialty should develop their own caring system for their patient to satisfy the patient. Why? What do the patient expect from us? When we see a patient, what does the patient expect? A rural fellow expects that I'll dispense them the drug, maybe free of cost. I don't know whether it is practical or not to give every medicine free of cost, but forget about that. A fellow expects the drug to be dispensed. Now, obviously, in our telemedicine system, we can't dispense the drug. But if you are not dispensing the drug, the next expectation patient has is a prescription. Now, most of the time, when you do a telephonic consultation, you do not, or you are not able to give a good quality standard prescription. But in our system, we developed that strategy. You can see here that whenever I see a patient with this system developed in the platform that I told you, the patient clicks here. You can see a paper and pen, and the patient clicks here. The moment patient clicks here, actually it will ask for the username and password of the patient. Why this is important? Because if I'm a patient, I expect my consultation to be privately available to me, and it should not be available to every public. So therefore, this is password protected. So patient use their own password and username to download the prescription. And the downloaded prescription looks like this. It has in the top Sanjay Gandhi Postgraduate Institute of Medical Science School of Telemedicine and Biomedical Informatics. It has the SGPGI logo. It has the logo of School of Telemedicine. And these are automatically done by the system. It is not that I insert the logo in my prescription. It is not that I insert the SGPGI name in my prescription. It develops automatically by the electronic system that we develop. Also, it doesn't call it as a prescription. You know why? Because when we were developing it, till the teleconsultation was not legally approved, but I tell you, within a few days, it got approved in an emergency. So it says only suggestion form. Now it captures the name of the patient, it captures the age of the patient, his gender, it captures the CR number, it captures referred by, it captures the date, the thing which the patient entered, all these are captured by the prescription or by the system. Now, subsequently, whatever history I wrote, the history comes automatically. Whatever investigation result I wrote, it comes automatically. And then in the bottom, it writes, it is a teleconversation. It doesn't say consultation, it says conversation, because consultation also includes a physical examination. Therefore, we are saying it is a teleconversation. And you are requested to come physically as soon as possible. It is also telling it is being offered to you during COVID-19 pandemic as a sort of as a good gesture to help you, so that this disclaimer remains, so that tomorrow something wrong doesn't happen. Now, patients were very satisfied. Look at this. When we asked the patient, "Are you satisfied?" Actually, 16 of 50 said very satisfied. 32 said satisfied, and 2 were neutral. None said I'm dissatisfied. 16 said I'm very satisfied. 32 said they're satisfied, and 2 were neutral. When we looked at, were the urban area people more satisfied or were the rural area people more satisfied? Urban area people were more satisfied than rural area. We know possible reason could be connectivity problem in rural area. But interestingly, urban area people had to travel a longer distance to reach SGPGI than rural area people. Till they were, urban area people had to travel lesser distance to reach SGPGI than rural area people, but still they were more satisfied. Why could it be this? This may be related to fact that urban area people are usually more earning people. They have more value to their hours. And that's why when they did not have to come to SGPGI and waste the whole day, we know what is the situation in SGPGI. If you line up at 5 a.m. in the morning, you may get a chance to see the doctor maybe at 4 p.m. in the evening. So your whole day is gone practically for one consultation of 10 or 15 minutes. And we all know that rural area people will still like to come to Lucknow, because many of them might not have seen Lucknow or a city very well. So they are actually asking for physical consultation more than a urban area people, in spite of the fact that urban area people had to travel less. We also looked at how commonly our IBD patient, 50 patients, because we all know all IBD patients are all on multiple immunosuppression. They are on multiple immunosuppression. And current conjecture is, if a fellow is receiving multiple immunosuppression drug, he's more likely to get COVID-19 or at least SARS-CoV-2 infection. So with that in mind, we wanted to see, are our IBD patients getting COVID-19 more often than healthy control? What we found, out of these 50 patients, only one had COVID-19. On the other hand, during the same period, we compared the data of these 50 patients with 16,000, maybe more than 16,000 healthy people who otherwise got tested for SARS-CoV-2 in microbiology lab. We compared the data with them, and we found there was no difference in the frequency of COVID-19 among patients with IBD in spite of multiple immunosuppression drugs than the healthy control in the community. Somebody will ask, how did it happen? I will tell you, we asked from them, from the IBD patient, how commonly did you use mask? How commonly did you meet visitors? How commonly did you go out of home? How commonly you washed your hand? How much was the fear of COVID-19 in you? And we found that they were following these preventive practices very often. I tell you, median number of time of washing hand every day by our patient was 8 times. So 8 times they were washing their hand in spite of being rural areas is too high a number. Almost 98% said they were always using masks whenever they went outside. Medium number of outdoor visits per week was 1 to 2. That basically shows because they knew they are IBD patient, they knew they are having lot of immunosuppression treatment. So therefore they were caring to prevent COVID-19 or SARS-CoV-2 infection by using these good practices. So that actually reiterates that all patients who are diabetic, all patients are immunosuppressed, all elderly people, all those who are on immunosuppression drug, they should actually use these healthy practices, and these preventive practices are useful to prevent SARS-CoV-2 infection. Our data further substantiate that. Also, we asked what was their quality of life during COVID-19. To our utter surprise, their quality of life was better during Corona pandemic. Can you imagine this? Can you believe this? So actually, they said their quality of life was better during COVID-19 pandemic, because we had a consultation available with us about 3 months or 6 months before, when COVID-19 pandemic did not begin. And at that time, as a part of the protocol, we were asking them about their health-related quality of life. So therefore, we had the data to compare. And when we compared the data during this teleconsultation, their quality of life was better. You will not believe this, but I have an explanation for this. Explanation is, in the initial consultation, most patients had acute flare of ulcerative colitis or Crohn's disease. So when somebody has acute flare of ulcerative colitis or Crohn's disease, they were going 8 to 10 times stool a day. They were having passage of blood in the stool. Obviously, they were worried. Their quality of life was poor. And during the COVID pandemic, because they received treatment from us, already their disease was in remission in more than 95% of the patient, and therefore their quality of life was better. Only thing is, they reported to us that their environmental quality of life scores were poor. What are these environmental quality of life scores? These are related to travel. These are related to leisure. These are related to healthy environment. These are related to entertainment. We can understand that when there is a lockdown, the leisure activity, the travel, the environment safety or environmental friendliness, all were reduced, and that's why environmental score actually became inferior. This further reiterates that if you care for the primary disease which the patient is having, that may be IBD in our case, it may be uncontrolled diabetes with an endocrinologist perspective, it may be coronary artery disease in a cardiologist perspective. So care of the primary disease is very, very important, in addition to our care to prevent COVID-19 infection and our aim to care for the patient who got the infection. So till now, our response was an emergency to actually do an immediate thing, how to control the corona. Now we realize we have to live with COVID-19 or SARS-CoV-2 virus. Therefore, we cannot ignore the so many diseases that the patient was suffering from. The hospitals there are built for tertiary care to treat those difficult diseases. Fortunately, our patients' mortality due to COVID-19 was less. In fact, only IBD patient who was on multiple immunosuppression, he had non-alcoholic fatty liver disease. He was morbidly obese. His weight was more than 110 kilo. But he did well with COVID-19. So we have a lot of explanation for this observation, why COVID-19, fortunately, till now, has not been so fatal in India compared to Italy or US, but I'm not going to deliberate on this here. So therefore, I conclude that COVID-19 pandemic is on. India has done reasonably well to control this pandemic. Now what happened is, but maybe in spite of all the vaccines coming, we may have to learn how to live with SARS-CoV-2 virus. Maybe it is not going to leave us soon. And therefore, we have to develop our strategy for future care of patients with multiple other diseases in addition to COVID-19. Thank you so much. If there are any questions, I'll like to answer. Dr. Bonju, do you have any question? Dr. Manju? Dr. Shukbi, do you have any question? Dr. Akir, do you have any question? Any question from anybody? Is there something in the chat? No, nothing in the chat.
No, sir, it's clear. Thank you.
Network issue.
Can you post your question in the chat, because there is some network issue? You can post the question in the chat. Yes, tell me. Dr. Akif, tell me.
No, sir, no questions here.
Okay, thank you.
Thank you.
Okay, if there is no question, thank you so much for listening. Thank you.
Thank you, sir.
Thank you.